Thoracolumbar spinal disorders in pediatric patients. I'm Thomas Buell. I'm a neurosurgery resident at the University of Virginia. Disorders of the pediatric thoracolumbar spine include a remarkably diverse range of conditions. It can be broadly subclassified as congenital, neuromuscular, and idiopathic. We will review basic clinical and imaging evaluation and discuss non-operative and operative management. Treatment requires a multidisciplinary team and must proceed out of respect for the growing spine, aiming to maximize growth potential. We review a new classification from the Growing Spine Committee of the SRS and conclude with emerging strategies to reduce surgical complications. Initial evaluation of a pediatric patient with a suspected spinal condition begins with a complete history, including prenatal and birth history, as well as cognitive and motor developmental history. Abnormalities of other organ systems are often associated with congenital spinal disorders and should be reviewed. Basic physical examination includes assessment of posture in different positions, the Adam Ford bend test, which may be used to assess for rib or transverse process prominence, indicating underlying scoliosis. Examination should also include general assessment of the head, entire spine, and extremities, including the skin, for capiolae spots, freckling, hair patches, or midline dimpling. General neurological assessment should be performed. Initial evaluation often includes full-length 36-inch spinal radiographs to enable assessment of global and regional spinal alignment. Global, coronal, and sagittal measurement is demonstrated in panels A and B respectively. Flexibility of scoliotic curves may be assessed with radiographs while the patient is bending to the left or to the right, such as panels C and D. CT imaging can provide greater detail of bony anatomy, such as hemivertebra or unsegmented bars. MRI can be used to evaluate for canal or foraminal stenosis, as well as intraspinal abnormalities such as tethered cords, syringomyelia, and tumors. Finally, progression of deformity in the pediatric spine is typically related to the level of skeletal maturity, with greater remaining growth potential corresponding to a greater risk of deformity progression. Several methods for assessment of skeletal maturity are listed. Reflective of the complexity of embryogenesis, a broad range of congenital spinal disorders may occur. Although many congenital spinal disorders may not be evident at birth, each is thought to result from errors that occur during embryogenesis. Congenital spinal malformations are not infrequently accompanied by other congenital anomalies, especially urological and cardiovascular abnormalities. Interspinal abnormalities are often also present. The next slides focus on congenital scoliosis and kyphosis. Lordosis and stenosis are rare and less common. Congenital scoliosis is distinguished from other forms of scoliosis by the presence of an anomalous vertebra at birth. Although the vertebral abnormality is present at birth, typically no evidence of deformity manifests until the growth phase of childhood or adolescence. Cases of relatively balanced spinal anomalies may even go undetected until adulthood, or may be found only incidentally. The type of anomaly is an important factor in predicting progression. Congenital abnormalities of the spine are classified on the basis of embryological development of the spine, with categories including failures of formation, failures of segmentation, and mixed anomalies. The most common result of failure of formation is a hemivertebra, which typically consists of a wedged vertebral body with a single pedicle and hemilamina. The most common segmentation failure is the unilateral unsegmented bar, consisting of a bony block including the disc space and facet joints. In severe cases of progressive congenital scoliosis, surgery is often the most effective treatment. Surgical options include hemivertebra excision, convex hemiepiphysiotosis, fusion in situ with casting or bracing, spinal instrumentation, and thoracoplasty with a vertical expansion prosthetic titanium rib. Here is a case example of a 6-year, 7-month-old boy with congenital scoliosis. Preoperative imaging demonstrates L2 hemivertebral anomaly. He underwent resection of the vertebral anomaly via an anterior approach and unilateral posterior instrument arthrodesis from L1 to L3. Postoperative imaging is shown after 1 year. Congenital kyphosis is a sagittal plane deformity that results from vertebral anomalies, including failures of formation and segmentation. It often results in neurological deficits if left untreated. Winter and colleagues devised a classification system in which 3 types of congenital kyphosis are distinguished: failure of formation of the vertebral body, or type 1, failure of segmentation of the vertebral body with ventral unsegmented bar, type 2, and the more rare mixed failure of formation and segmentation, type 3. In general, non-operative treatment is not recommended for congenital kyphosis owing to the significant potential for development of neurological deficits with progression. A posterior fusion alone may be adequate for patients younger than 5 years of age with less than 55 degrees of kyphosis. Combined anterior and posterior procedures are often required in older patients or those with greater than 55 degrees of kyphosis. And surgical complications are most likely if kyphosis is greater than 60 degrees and preoperative imaging demonstrates cord compression. This is a case example of a 24-year-old woman with congenital kyphosis. Preoperative radiographs and sagittal CT reconstructions are demonstrated. She underwent T10 and T11 vertebral column resections, cage placement, and posterior instrument arthrodesis from T7 to L2. Postoperative imaging is shown after 1 year. Spinal dysraphism includes abnormalities of spinal cord and column development. Dysraphisms have been broadly grouped into spina bifida aperta and spina bifida occulta. The intraspinal abnormalities associated with both spina bifida aperta and occulta can result in scoliosis, with variable severity and management based on the underlying etiology. Neuromuscular disorders include conditions affecting upper and lower motor neurons, as well as myopathies. Pediatric spinal deformity is a common consequence of many neuromuscular disorders. Curves are often long and sweeping, of great magnitude, and with pelvic obliquity. Therefore, surgical correction often warrants pelvic instrumentation. This patient population often has significant comorbidities. Therefore, this partly explains the high associated surgical complication rates. However, over the past decade, studies have demonstrated reduced complication rates, partly attributed to technical and instrumentation advancements. Scoliosis Research Society classification of neuromuscular spinal deformity is listed here. In this chapter, we've created a presentation dedicated solely to neuromuscular scoliosis and its management. Please refer to this presentation for further details. Adolescent idiopathic scoliosis is the most common etiology of pediatric thoracolumbar spine deformity, affecting approximately 2 to 3% of adolescent population. It's a diagnosis of exclusion after ruling out neuromuscular, congenital, syndromic, or other causes. In simplest terms, scoliosis is a lateral curvature of the spine greater than or equal to 10 degrees. More dramatic curves disproportionately affect females. Adolescent females outnumber males 10 to 1 for curves greater than 30 degrees. Curve progression is associated with larger curve magnitude, younger age, and lower Risser stage, which is a measure of skeletal maturity as indicated by progressive calcification of the pelvis. Further characterization by age of presentation includes infantile, juvenile, and finally adolescent idiopathic scoliosis. More recently, the Growing Spine Committee of the Scoliosis Research Society defined early onset scoliosis occurring in children less than 10 years old. Surgical indications. For growing children, surgery is recommended once curves reach 45 to 50 degrees. For skeletally mature teenagers, surgery is recommended for curves that exceed 50 degrees because curves of this magnitude have significant risk of progression in adult life. Pedicle screw constructs have become the mainstay of treatment when surgical fusion is performed. Goals of surgery are to restore coronal and sagittal balance, reduce the rib prominence, and achieve shoulder balance. However, another important goal is to leave as many unfused segments as possible to preserve motion in the lumbar spine. Therefore, in some cases, such as children with early onset scoliosis, non-fusion procedures may be used. In this chapter, we've created a presentation dedicated to idiopathic scoliosis and its management. Please refer to this presentation for further details. The Growing Spine Committee of the Scoliosis Research Society now defines early onset scoliosis as children with spinal deformities less than 10 years of age, regardless of etiology. A new classification has been developed and validated based on age, etiology, magnitude of the major curve, degrees of kyphosis, and annual curve progression. Our understanding and management of early onset scoliosis has changed rapidly in the last few years, with various non-fusion treatment options available. In the neuromuscular scoliosis presentation, we previously discussed the study by Cognetti and colleagues which reported a substantial decrease in complication rates. Similarly, for adolescent idiopathic scoliosis surgery, Launer and colleagues also demonstrated reduced complication rates. Other trends over the past approximate 20 years include cessation of anterior-only surgery, increasing utilization of all screw constructs for posterior fusion, decreased blood loss, increased use of antifibrinolytics, shorter operative times and length of hospitalization, and improved outcome scores. In the next slides, we discuss potential strategies to further reduce complication rates. Some studies have demonstrated that CT-guided navigation can improve accuracy of pedicle screw placement for adolescent idiopathic scoliosis surgery. Some surgeons even use image guidance during pelvic fixation with sacral alar iliac screw placement. However, a recent systematic review reported conflicting complication and breach rates when comparing intraoperative image guidance and traditional freehand techniques for screw placement. Augmented reality surgical navigation with intraoperative 3D imaging is an emerging technology that may also improve screw placement. In the first human trial of augmented reality surgical navigation for spine instrumentation, the authors reported that pedicle screws, most were thoracic, were placed with high accuracy under acceptable navigation times. Intraoperative neuromonitoring is commonly used during pediatric deformity surgery. Transcranial motor evoked potentials may be more sensitive than somatosensory evoked potentials. However, utilization of both together may offer further benefits and improve safety. Samdani and colleagues demonstrated notable signal changes in 5.3% of the patients who underwent adolescent idiopathic scoliosis surgery. The authors reported that return of signals helped guide the surgeon to safely complete the operation in 34 of 36 cases. When performing surgical correction on patients with syringomyelia, surgeons should be aware that larger syrinxes may have less reliable neuromonitoring signals. Administration of tranexamic acid, an antifibrinolytic, may reduce surgical blood loss and transfusions in adolescent idiopathic scoliosis surgery. A recent RCT reported significantly reduced blood loss with TXA administration compared to placebo. Also, the authors reported a significantly lower rate of intraoperative blood loss per hour and per level fused. More placebo-treated patients had blood transfusions, and patients with greater blood loss had increased hospital stay. No adverse effects associated with TXA administration were observed. Disorders of the pediatric thoracolumbar spine include a broad range of conditions arising from congenital, neuromuscular, syndromic, and idiopathic causes. Effective care of pediatric patients with spinal disorders requires an understanding of the conditions encountered, the means by which the patients are clinically evaluated, and the strategies, both non-operative and operative, by which they are managed. Benefits of clinical improvement likely outweigh the risks of surgery for appropriately selected pediatric patients. Recent advancements in spinopelvic instrumentation and other potential techniques such as intra-wound antibiotics, image guidance, intraoperative neuromonitoring, and use of antifibrinolytics may further reduce complication rates.